Our next speaker, measuring potential and actual harm from medication errors, Dr. Virginia Mumford and Ms. Erin Fitzpatrick. Dr. Mumford is a Senior Research Fellow and Applied Health Economist at the Australian Institute of Health Innovation. She combines a background in clinical medicine and finance, looking at complex problems. And Ms. Fitzpatrick is a Research Officer at the Medication Safety Arm here at the AHA. She has a decade of experience as a clinical pharmacist. So I'd like to invite you both to the stage.
Very much. We'll try the clicker. So this is where we take you to the pointy end. We've heard a lot about potential harm, and we're now going to take you through how we designed a process to actually measure actual harm in patients. It was very long and tortuous. We're going to go through the steps in the process in terms of identifying errors, assessing potential harm, which Joanna's touched on and Magda's also done in terms of the administration errors, and then go through preparing how we prepared case studies and the actual multidisciplinary panels we convened to measure actual harm. But first of all, Erin's going to take you through the initial steps of that process. Thanks, Erin.
Okay, firstly, just to reiterate some of the things that Joanna touched on at the beginning about our processes. So the first thing is how we actually identified and defined harm. The prescribing errors. So a prescribing error was defined as anything that deviated from standard paediatric prescribing guidelines. Just a few of the categories listed there. So dose was plus or minus 10%. Frequency, route, drug-drug interactions, allergies, drug monitoring, complex infusion, rate and concentration issues, and anything that was specific to the patient and their disease and conditions. So in general, the references used were anything in CAP, which for those who aren't familiar with it is the information portal for New South Wales Health, most specifically the AMH Children's Dosing Companion, the BNF and Up to Date. The hospital, Children's Westmead, has their own internal prescribing guideline, Meds for Kids, which was used a lot, particularly in the initial rollout period, as that was the standard guideline at the time. We also looked at hospital and network policies and protocols relating to the drugs, and we also used a few other Australian clinical guidelines, such as the Royal Children's Hospital Guidelines. So once an error was identified, we then went and classified the potential harm that that error may cause. So basically what we were looking at is if that error was to reach the patient, what would we expect to happen? And these range from minimal harm, so essentially we would expect nothing or very little to occur, temporary harm where we may require additional monitoring, through to more serious harm that would require clinical intervention and could result in either temporary or permanent harm to the patient. So those that was considered serious harm were then put forward to the process of developing the cases for the clinical harm panel. So firstly, we needed to determine whether the harm actually reached the patient. So often the errors were intercepted before they reached the patient. We needed to look for evidence that the medication was actually administered from the order with the error. And often, even if it was administered, the total dose or daily exposure was below dangerous limits, and so these were not considered harm. And it was assumed that any administration error reached the patient. So when looking for evidence of harm, we look through the entire patient record, including patient notes, between the flags, clinical results, internal and external correspondence, including clinic letters, referrals and such. And the nature of the error would often dictate how much of the clinical record was needed to be looked at. So for example, if something would be expected to cause harm within 24 hours of being administered, we would look at a day or two. If it was something like an anti-rejection drug where the effect of that might not be seen for several years, we would look at a few years of the record to determine if there was any harm. For the top 10 drugs that had errors, we created the FAME guidelines, which were standardised guidelines that were created with clinicians detailing the expected outcomes from either higher or lower doses of medications. So you can see the top 10 drugs there. fairly standard ones in paediatrics: antibiotics, pain meds, anticonvulsants, antiemetics, high-risk drugs such as insulin and potassium fluids, vitamin K and zoledronic acid. And also there was quite a few errors where we had to determine if medications given by an oral route had caused harm in patients who were unable to tolerate their medications orally.
Thanks, Erin. So if we look at, there we go. So one of the FAME guides, obviously the opioid is a very easy example to use. And this sort of highlights the sort of case study approach that we were going to be taking. So anyone who's presented at an M&M will know that this is a very standard way of clinically presenting a case. For these particular FAME guides, we looked at the symptoms for both a lower dose or too higher dose. So too low and slow in some cases, or too high, a higher dose or higher concentration in the other. And so we looked at the symptoms, for example, drowsiness if you have too much of an opioid, signs, may see pinpoint pupils, any medications that were given as an antidote, for example, is a red flag. And we looked at other tests that may have been done to determine how the patient was responding, any actions that were occurring in terms of higher levels of care that were needed for that patient. And we looked at the care record because we were looking not only at the sort of issues around that particular patient during their stay in hospital, but also the impact of that error and that potential harm on the patient in terms of their overall care. So this was some of the case studies, a sort of example of the case studies that we produced. So general details of the patient. You can see this was a young male child brought in. The reason for the visit, fever and vomiting, and we had the diagnosis of the past medical history of the patient. This is sort of just slimmed down to get on the screen, and they came in with a strep urinary infection, and they were in for 9 days. They're quite sick. We then highlighted what the actual issue was, and we used the term drug event rather than error. It was just easier to deal with as a non-emotive word. And in this case, it was the wrong bolus injection rate. So this was a Ben-Pen injection. And from Magda's presentation, where we talked about administration errors, you'll see when we talk about the actual harm from administration errors, this is quite a sort of common issue. So what we did is describe exactly what happened, what they were given, and in this case, we just highlighted it was given as an IV injection over 51 seconds, which is below the recommended rate of over 5 minutes. We would then, for the people on the panel, give some data about what was the recommended dose or route or whatever the drug event was relating to, and also any issues that relating to the supporting document that were available to the clinical team at the time. So the symptoms for this patient, they'd been irritable, difficult to feed. We then stated when the actual drug event was. They could see it in the context of what was going on. And then for the signs, in this case, what we did is to make it easier to understand the signs in relation to the drug event, we put the details of what the potential harm would be for a fast bolus rate, which is obviously a tissuing of the drip. In this case, it happened just within half an hour of the actual bolus being given. And in this case, the anaesthetist was called to, the resident tried to recite the drip, but then the anaesthetist was called, and eventually the drip was recited. So the actions in this case was the doctor reviewed the patient. They also contacted the infectious diseases team to see if they could switch to oral, and they were told, no, we've got to get IV antibiotics into this kid. So the anaesthetist came to recite the drip. Again, took several goes. Very sick child, probably shut down, not surprising. So in the care record, the things we were looking for in terms of identifying things that would be associated with this for potential harm would be, the doctors obviously spoke to the parents about what was going on and the need to try and recite the drip in order to continue with the IV antibiotics. So the actual process for measuring the harm is we presented these case studies that we selected to our wonderful and long-suffering teams of multidisciplinary panels. So for each one, we had a paediatric nurse, a paediatrician, and either then a pharmacologist or pharmacist. with experience in paediatrics, because it's a very different set of demands looking at paediatric drugs rather than adult drugs. And so for each of these, the panels that we held, we presented these case studies. In many cases, for the more complex cases, we sent them to the panellists ahead of time and then asked for their feedback. And what we were asking for, the main question was, did the case study provide any evidence that the patient experienced harm that would normally be associated with that error? So we were asking for them, not did the child have harm, we were asking, did you see any evidence of this? And if they said no, well, what's the confidence there was nothing in the care record that would describe any harm? If they said, well, yes, they saw something, then we say, well, okay, describe what you saw from the case study. What level of harm would you rate this at? And also then, at the very last moment, link it to say what was the sort of link between what you saw as the harm and what actually happened. And then for a few drugs, they were just unaccessible because we just didn't have enough information in the medical record. So to give some sort of numbers, we looked at over 26,000 orders, and Erin, the heroine of the hour, personally reviewed over half of these. The total number of errors was quite high, but the errors with this serious potential harm that needed some form of intervention was much, much lower. And then we prepared a number of case studies for the actual panel. Now, some of these ones where there was a potential harm rating was serious, but in some cases they didn't actually receive the drug. So a duplicate obviously has high potential harm if you've got a duplicate of paracetamol of a PRN rate and a standing order. But if you weren't given that, then it wasn't an actual harm. So there was a lot of sorting out and discussing to do. And so we whittled it down to the 173 case studies for the prescribing orders. For the administrations, just over 4,000. And we ended up with 393 case studies for panels. What was interesting is, of these prescribing orders, you start off with over 26,000 orders. The actual numbers where there was actual harm in these panels was vanishingly small. This is a huge tribute, I think, to the system of trying to keep kids safe in hospitals. So there were 22 harms from the prescribing orders and 67 harms identified from administrations. And these are mainly in the mild to moderate harm, just a couple in terms of serious harm, and none in the severe harm category that we were using, and then 6 unaccessible in the prescribing and 5 unaccessible in the administrations. And I say this is really due to the fact there just wasn't enough in the moats to sort of justify identifying whether there'd been harm or not. So the real story behind this, as Magda also kind of highlighted in her talk looking at administration errors, is that for the actual prescribing orders, it was a fairly diffuse picture in terms of the harms that occurred, and there are only 22. For the administration errors, it was a much clearer picture, and one that we want to really discuss today. So on the left-hand chart, you can see that what we've done is highlighted the errors, the case studies that went to panel, and the harms related to those by age group. And you can see that for those that had harm, it was very much an issue of the younger age groups at the bottom of the slide. And so these dark areas are the ones where there's actual harm from those. So it's roughly about half actually had harm, and mainly in that younger age group. We then wanted to look at what was causing this harm. And so this is clearly an antibiotic problem that we can see from the left-hand side. So half of the harms due to antibiotics, but what was it about these antibiotics that was causing a problem? And in the right-hand one, what we did, we looked at the antibiotics, and we looked at the roots and the other issues and the type of error that was causing this harm. And I've got a nice sort of slanting line showing the preponderance of wrong duration, and this is fast duration. So the real story behind the harms from administration errors is drugs being given with too fast a push, and especially with antibiotics. And so this is something we feel is a real picture that can be taken away, something that can be addressed either with changing the order routes in the EMM, training, And a lot of that is to try and reduce this particular issue in children's hospitals. Any questions?
We do have time for questions, so...
Hello, Edel Murray here from St Vincent's Health Australia. And fantastic data. Myself and my colleague have been interested in medication data for a very long time. Have you overlaid this data with the incident reporting and near-miss data?
We're starting to do that. What we found is that, we're going to talk about this later on today, but one of the problems we had in identifying harm is that very few of the errors that we actually captured during this process were identified in hospital. So the incident reports wouldn't have been written for these ones. And when we were then trying to capture what was the impact on the patients, we couldn't, there was no testing done because the error hadn't been identified. There were no, perhaps antidotes weren't given because the error hadn't been actually identified at the time. So it's a very difficult thing to test with the incident data, but one of my colleagues is going to address that later on. So we'll park your question for a bit.
Question down here, Mike?
Probably speak loud enough. The numbers you saw there are very small compared to the denominator. I think the challenge to the audience here is going to be, if we were to institute, looking at my design team, linking up with you guys from the research, you're pointing us in the direction of two, incorrect dilutant and time, the actual giving. We could design those out. The challenge being 26,000 events will now then impose, say, a clock timer. Every time you were to give intravenous antibiotics, we could even be more selective, you then have a clock time. We could do something of that nature, but now you're going to have 26,000 denominated, impacted on. And I think the challenge there, first and foremost, I'll be looking for my research colleagues to show what that, even if that does have an impact. I think the dilutant was someone that mentioned earlier on the barcoding potential. Some of those, again, can be engineered that you can't combine barcoded. But again, remember, that's 26,000 of those confirmation checks that have to be done. And I think from the previous presentation, the challenge I had was the 6.4 minutes. Again, the big worry here, George, is, as you called out, for more nurses, for many different reasons, but one of our biggest concerns for any design or digital is we start to impose a new time tariff. And I'll be interested to hear from our colleagues here whether they would like to join on a design/research. But remembering that's 22 events, and I think you've given us two very clear groups of events there. But I would always have caution on the 26,000 cases we would now overlay.
And that's why exactly, and I think that's why it's a very challenging area. And I think also, just in terms of, we were talking about how to sort of redesign systems, of not having a bolus rate as a top thing coming up in the order flow, and especially for the younger age group, the sort of less than 1 year, it not. The bolus thing not being there, just IV infusion, perhaps is a way forward. It's very difficult as a nurse, I think, to stand there for 5 minutes. You don't have that 5 minutes in your day to do that. So I think that's a challenge.
Just the one thing that I just would reinforce, I think, is that while there were only a small number of cases that had harm, I think that's fantastic. And then there were a few cases where we said it was absolutely unaccessible because of what was in the record. But the vast majority, as Virginia said, of errors, no staff had detected it. And so the level of documentation, if you're not looking for an error, you're not going to be documenting any information, you're not going to be doing any tests. And we know from some US studies where they were focused much more on identifying harm associated with errors, they took an approach. They not only used the record, but they did it in real time. They spoke to clinical staff at the time that an error was identified, and they found a much higher rate of harm. So I think put it in context, this is probably an underestimation of the true error rate as well.
So we're not just better than the Americans, it's not... Where were we?
We probably are better than the Americans, but...
Quick question up here.
Hi, Kate from Northern Beaches again. Can I just make a comment on perhaps particularly design and thought that goes into describing medication orders, so a nurse knows how to give it. The route's intravenous. The form, it's the description of the form, how you want to describe that to inform them how to give it. It comes in a vial, so you need to call it injection, short infusion or infusion. And these are really simple things that you can do now. I actually thought it was done in these systems because we discussed it at eHealth years ago. I'm a little bit intrigued about it, but it's certainly a solution we've had in place for many years. And you know, things don't come how the nurse gives it a lot of the time. So we've really got to be careful. And to also put a caveat on it, these things don't exist in AMT or SNOMED. So there's some of these things that if you're, again, asking vendors to use coded information, that they don't actually exist, and you've got to create these forms. I think it's a really important thing to look at, because I think you could solve some of these problems pretty fast.
One of the comments, as the person who looked at 26,000 orders, particularly in that initial phase where prescribers didn't really understand the impact of bolus versus intermittent and why it was there, they were defaulting to bolus a lot of the time, which I think would have contributed to a lot of these faster pushes, simply because that's what the order said to do. And even if there was an order sentence, you would often notice that they'd play around with it a bit and then go, oh, whoops, and go back to bolus. So I think it seems to have improved now, but initially in that first period where they didn't understand the implications of what that little drop down was doing to the patient, there was a lot more bolus there than I think should have been there.
Fortunately, we're moving on. Thank you very much for joining.